So yeah, as Sherry said, my name is Dylan George. I'm a PhD candidate. Really happy to be here. My first time down in Atlanta. Oh, wrong way. So yeah, today we're going to talk a lot about fingerstick blood and SARS CoV-2, and we're also going to chat a bit about our initial assay that we've built to measure the humoral response in plasma and serum. And a lot of this work has been done on the XMAP and Teleflex platform, which is really cool. So first off, who are we? So I am part of the Emerging Pathogens Laboratory at UNMC. And our director is Dr. Jana Broadhurst. She's the clinical director of the Nebraska Biocontainment Unit. This is a biocontainment unit that's gotten a lot of national coverage over the years with some different outbreaks. And so what we focus on at EPL is kind of expanding access to testing and eventually, healthcare to populations that very often have not, had that access. So we have a picture here, Spit for Science. This is one of our activities where we go out into the community, engage with folks, and try to capture as many samples as we can from people who are not going to be presenting to healthcare scenarios. So building off of that, what we do, here's one of our wonderful summer students operating a COVID-19 saliva testing site. So EPL was one of the first labs in the nation to develop a COVID-19 PCR test. And we also then adapted it with the Yale Saliva Direct method to start providing the saliva-based COVID-19 PCR screening, both to the Nebraska Medical Campus and the Omaha community, but also also a large amount of people across the state of Nebraska, including several Native American tribes. So that all gets at, what we actually do. We develop assays, both serology and diagnostic applications. So obviously we do SARS CoV-2, but we also have been working a lot on some really fun pathogens like Ebola, Schisto, Chagas disease, and some more. And a lot of this work, not all of this work is happening on Luminex technology, but a lot of what's listed here is currently or will be in the future. So then how did this all start? So obviously 2020 we have the outbreak of SARS CoV-2, and at the very beginning we wanted to decide which proteins to even use in this assay, right? Obviously at the start of a pandemic, there aren't, commercial sources for a lot of these proteins. So we partnered with another lab to produce, proteins against SARS-CoV-2, spike 1, spike 2 proteins, nucleocapsid, the ectodomain, all of these different proteins. And we were then left with, well, how are we actually going to measure these things and the antibodies to these different proteins? So along came Luminex. And we started all of this work with a MagPix instrument, and the entire reason we did that actually is one of our collaborators who is working overseas happened to have a MagPix sitting in a Pelican case for about 10 years. So we brought that out of storage and it worked great, and as other people have alluded to, it was a really great platform to screen a lot of different proteins in a sample set, and it saved us a lot of time. But what we found eventually is that a lot of our proteins were actually giving us some pretty nasty background signal. And so, once we got further into the pandemic and there were some more commercial sources for proteins, we had to kind of switch up our assay a bit and more or less start from scratch. But at the same time that we were, down in the dumps realizing, oh no, all of this work, for nothing, all of a sudden we got access to the XMAP and Teleflex, and so this was a really fun opportunity to work on a new instrument with essentially a new assay. And so using this in Teleflex, we've developed this in-house kind of homebrew assay that we're calling HumourX, and we're able to measure IgG, IgM in both serum and plasma. And then we've spent this past year or two testing a lot of really cool, really massive cohorts of subjects. And all of that leads to the thesis of today's talk, which is validating fingerstick blood on the XMAP and Teleflex platform. So then what is our goal with this? Well, we want to be able to determine antibody profiles in various cohorts, and how does that correlate with protection, obviously. But we also want to focus on developing these really high throughput capabilities, right? If we want to help people and capture samples from folks that may not always be presenting to the healthcare setting, right? There's obviously a lot of those samples out there, so we want to be able to rapidly screen at low cost, very large number of samples. Now the next image, Luminex should probably pay me for. So this is me being extremely happy when our IntelliFlex arrived because, right, using the MagPix and testing multiple antibody isotypes, we were separating these out into multiple wells. And so from this point, we were able to combine those into a single well, and that made my life a whole lot more fun as a grad student. So like I mentioned, this assay that we're working with on the IntelliFlex is called humoral, and it is a dual reporter assay, and we're able to quantify, right now, we're able to quantify anti-receptor binding domain and anti-nucleoprotein antibodies. So just highlighting the proteins on the SARS virion that we're actually targeting, right? So why do we want to capture both of these? Well, most of this audience is probably aware, but the mRNA vaccines are only going to elicit a response against the RBD. So if you had an individual who only had RBD antibodies, that person may have just been vaccinated only. Now this has become a lot more complicated because we've since found that nucleoprotein antibodies don't stick around nearly as long as RBD. But in general, the theory here is that we want to be able to differentiate vaccine versus, quote unquote, natural infection antibody response. And here, just a few key mutations in our Omicron lineage. So in addition to this, vaccine versus natural exposure, we're interested in antibodies elicited against new variants that come up. So we're focusing a lot on Omicron BA.5 and Omicron XBB right now. So just to give you a little bit of the validation for the plasma assay, I have here percent CVs for our positive control dilution series, and then the boxes highlighted in blue there are the linear range of our assay. And so what we can see is that most of our CVs are really good. A lot of them are less than 5%. All of them are less than 7%. So we have really, really great reproducibility with this assay so far, and that gives us a lot of confidence kind of moving forward. And then the other piece of validation data that I wanted to show is here. So start you off. So the titles on these graphs are the antibody that we're looking for, right? So IgG against receptor binding domain from the Wuhan strain, as well as nucleoprotein IgG elicited against their canonical strain. So on that x-axis, from left to right, we're looking at pre-pandemic samples. So these are plasma samples collected prior to the outbreak of COVID-19. So the criteria there was, I think, just prior to November 2019, and most of those are much older than that. And then the next 3 bars represent COVID positive individuals by a PCR test. So the way this would work is, say you presented to Nebraska Medicine or an affiliate hospital and you received a positive COVID-19 PCR result, and then you come back in 2 weeks and then they take your blood. In that case, you would fall into this day 15 to 90 category. Those are the blue bars on this graph. And then finally, that red dashed line is our positive negative cutoff, which we set 6 standard deviations above our mean. So you can see by the numbers listed on top of the bars, maybe they're a little bit small, but in that kind of middle category, that day 15 to 90, we're getting 100% positivity among known COVID-19 PCR positives. So we see a similar result, about 95% positive with our nucleoprotein, and we're really excited about this, being able to detect not only such a wide range of antibody responses, but being able to accurately call people who've experienced exposure to the novel coronavirus. Now, like I mentioned earlier, we're interested in kind of high throughput capabilities, and there's obviously some problems, if we do want to get out into the community and screen large numbers of samples. So that is, first we need a tool that's actually, distributable to actually lower that bar of entry into the study. So, right, with plasma or serum, most of the time you're going to be presenting to a hospital and having a phlebotomist actually draw your blood. That is not something that we can rely on for this. So we want to move, So we want to move towards fingerstick blood for this. And then this tool also, right, needs to be cheap, easy, has to be reliable for people who are non-healthcare personnel to actually use and collect good samples. To answer that, we're using the Neoterix Mitra fingerstick collection device. So I've chatted with a few people today about this. So these are a bit different than dried blood spots in that at least the claim from Neoterix is that they are absorbing precise volumes of blood, either 10, 20, or 30 microliters. And so, right, this is huge for sample adequacy, right, and making things kind of uniform across participants. You can visually see when the swab is saturated with blood. And so, in theory, you are collecting the same volume of blood from every patient. So these have been a lot of fun to kind of validate and work with, and I think they're, a really interesting step kind of away from the normal dried blood spot approach. Now, to get into this, right, we needed to validate our fingerstick blood. Problem, we don't have a ton of fingerstick blood sitting around from before the pandemic. So the first thing that we did is we wanted to contrive negative samples onto our fingerstick collection devices. So in our normal assay, right, we're taking serum and we're running that on our assay humoral, which is ran on the IntelliFlex platform. And then to validate the negatives, right, our pre-2019 negative samples, we're going to take a known volume of that pre-pandemic serum and pipette that onto the end of these fingerstick collection devices, elute them per manufacturer instructions, and run them as if they were, actual fingerstick samples. So this graph is the same in every regard as the one I showed you previously, except these are those contrived fingerstick samples. So these are now a subset of that initial validation study. And you'll notice we have lower sensitivities. So for our receptor binding domain antibodies, we're only getting a 94.7% positive rate in that kind of that middle day 15 to 90 category where, in theory, we should be able to catch pretty much everyone's antibody response. And then for nucleoprotein, we see a similar effect down from 95 to, I think, 89%. So what's exciting here, though, is that we are still able to capture, a breadth of different antibody responses, and we're able to maintain some level of sensitivity even in these contrived fingersticks. But then how do contrived fingersticks actually line up with the results that we get in serum? So what we did is we took just our same samples, we ran their serum as we normally would, and then we ran them as a contrived fingerstick sample, and we had fantastic concordance. So the two kind of obvious outliers are the same between those two graphs, and I don't have great explanation for that right now. But you still see that even with those two weird outliers, we're still getting, 0.94, R squared or 0.92 in the nucleoprotein. So we're seeing really good results corroborated between our plasma serum assay and our fingerstick blood assay. So same graphic as before, but now we actually want to use real fingerstick blood, not stuff that we've contrived. So to do this, we have a cohort of people for whom we have collected paired samples. So we get a fingerstick blood as well as a paired sodium citrate plasma sample. And we wanted to see, how does this compare with our kind of contrived results. Now, this is part of a really fun prospective longitudinal observational cohort study running since the beginning of the pandemic with folks from the Diamond Princess all the way up to people that are still enrolling. So this is a really fun cohort that spans the entire course of our pandemic. And what we did here is we took just 16 of those for which we actually had paired plasma and fingerstick blood. And we just looked at, how are those results kind of lining up. And what we see is we still get really, really great concordance between our fingerstick and our plasma data. So still above 0.9 for RBD, the canonical strain. But you'll also notice here, instead of the N protein, we're looking now at the Omicron BA.5 receptor binding domain and antibodies against that. So not only can we capture these canonical receptor binding domain antibodies, we're able to differentiate that from anti-BA.5 antibodies and still get really great concordance between our fingerstick data and our plasma data. So in conclusion, humorex is a really precise assay with excellent agreement to other reference methods for SARS-CoV-2, such as PCR testing. This is all thanks, obviously, to a close partnership that a lot of us have hit on today. Right, I would just say, people like Sherry and Steve and Bobby and Dominic have been super helpful in, getting this assay to where it is now. It's been a super great, super fun time working with all of those folks. And then fingerstick blood is a reliable sample type for detection of these relevant SARS-CoV-2 antibodies. Obviously, work left to do, but pointing us in the direction that we can get, good, reliable results from, the fingerstick blood without having to have patients present to a healthcare setting. The next steps for this, right, expanding our kind of use case for fingerstick blood. So not only looking at SARS-CoV-2, but looking at influenza antibodies and other diseases. And then also we're super interested in mucosal sampling and how that correlates with blood, as well as IgA in the mucosal samples. So obviously thank you to my entire laboratory. Feel free to contact us if you have any questions, or if you think about collaborating. I have our emails listed here, both for me and my PI. So with that, I will take any questions you have.